Okay, let's unpack this. Today we're diving into the remarkable world of mandibular orthognathic surgery.
Hmm.
Think of a field where, like, precision engineering meets the incredible complexity of the human body.
Right.
It's a journey that's evolved from, pretty basic bone cuts back in the 1800s to today's microsurgical techniques.
Absolutely.
It's really a testament to ingenuity filled with surprising discoveries about our own anatomy and a constant balancing act between risks and rewards.
Yeah.
So our mission in this deep dive is basically to distill the most important insights from a comprehensive look at this complex subject, give you a shortcut, kind of, to understanding the science and artistry behind reshaping the human jaw.
Indeed. And what's truly fascinating here is how the progress in these surgical techniques, it really mirrors the evolution of oral and maxillofacial surgery itself as a specialty. We're going to explore not just what changed, but, why it changed. We'll delve into the critical anatomy, the physiology, and that relentless pursuit of better patient outcomes and safety.
Mm.
It really is a story of constant refinement.
And here's where it really gets interesting, I think. Let's rewind the clock a bit and trace the remarkable history of how we learned to, well, move and reshape the jaw. You might be surprised how far back some of these foundational ideas actually go.
Mm.
So back in 1849, Dr. Holohan performed what's considered the first mandibular osteotomy.
The very first, yeah.
He literally reshaped a burn patient's jaw to correct an open bite. I mean, groundbreaking for the time, right? Even if it took decades for the medical community to really appreciate its potential.
Holohan's work was definitely ahead of its time. Then you fast forward to the early 1900s, and VP Blair, he popularized what we call the body osteotomy.
Okay.
That was for patients with an overly prominent lower jaw mandibular excess. And what's amazing is that this technique, with maybe minor tweaks, remained a standard for nearly 70 years.
70 years, wow.
Yeah. Blair also worked on the horizontal osteotomy of the vertical ramus. But that procedure, well, it ultimately taught surgeons a really crucial lesson.
Mm-hmm.
Without sufficient stability after surgery, bone segments just won't stay where you put them.
Right. They drift back.
Exactly.
Yeah.
That realization was a major driver for future innovation, figuring out that stability piece.
So stability was the big challenge. And speaking of those vertical ramus procedures, Limber was the first to describe a subcondylar osteotomy.
Mm-hmm.
Initially, it was an extraoral technique done from outside the mouth, but it laid the groundwork for the intraoral vertical subcondylar osteotomy, or VSO, that's used today.
Right, the VSO.
It's a good example of how the field evolved organically, sometimes with different names for very similar procedures, a bit of nomenclature confusion, as surgeons worldwide tackled the same problems from different angles.
That organic evolution, it led to other key techniques like the L and C osteotomies. Wassman introduced the inverted L osteotomy back in 1927. Then later, Pichler and Trauner modified it, and crucially, they added bone grafts when advancing the jaw.
Ah, the grafts. Important for healing.
Very important. Then Caldwell refined it further, creating the C osteotomy. The constant drive here was really about finding ways to move larger segments of bone, especially forward, and achieve reliable healing.
But the real game changer, the procedure that pretty much dominates jaw surgery today, that came in the 1950s, right? The sagittal osteotomy.
That's the one. First described by Abougizer and Trauner in 1955.
Yeah.
And even that pioneering technique, it needed refinement.
Right.
Delpont made key modifications to the bone cuts. Those were absolutely crucial for achieving safer, cleaner bone splits, and importantly, minimizing soft tissue trauma.
Safer splits, less trauma. Makes sense.
Yeah, this was a foundational step for the modern sagittal osteotomies we see, a point Hunsuck later emphasized too.
Got it.
And then came another, revolution really, in 1974. That's when Speisel introduced screws for rigid internal fixation.
Ah, the screws. That sounds significant.
Hugely significant. Before this, surgeons primarily used wires to hold bone fragments together. Imagine that.
Wires, yeah. Doesn't sound very rigid.
Not really. The ability to rigidly fix bone segments with screws, it just transformed how orthognathic surgery was done. It led to significantly more stable and predictable results for many procedures. It allowed the field to move forward with much, much greater confidence.
That whole journey from those first cuts to rigid fixation, it really highlights the surgical dilemmas they were facing. But, for all the sophisticated techniques, the body's own blueprint, its intricate network of blood vessels, nerves, muscles, and it still dictates so much, doesn't it?
Absolutely. If we connect this to the bigger picture, understanding these physiological foundations is just critical. It's the why behind surgical choices and, frankly, potential outcomes.
Okay.
Take vascular supply, for instance, the blood supply to the jaw. For a long time, the inferior alveolar artery, the INN, was seen as the mandible's main lifeline.
Right, the main pulp.
Exactly. But Bell and Levy's pivotal studies in the 1970s, they really challenged that assumption.
How so?
It was a true paradigm shift. They showed that the periosteal blood supply, essentially blood flow coming from the surrounding soft tissues,
Mm-hmm.
could actually be enough to nourish mobile jaw segments and even the teeth.
Even the teeth?
Yeah, even if the IN was compromised or cut.
Wow. So the body has a backup system.
Precisely. A remarkable redundancy in the design. However,
Yeah.
there's always a however in biology, right?
Right.
Newer research adds an important nuance. Think of the INN like the main highway for blood flow to your jawbone.
Okay.
If that highway gets blocked, smaller back roads, these collateral vessels, they can step up. But crucially, it seems they only really work well for the anterior part of the jaw, the front.
Ah, so not the whole thing.
Exactly. For the posterior mandible, where your molars are, those back roads just aren't enough. Studies in dogs by Zisser and Gattinger even showed pulpal necrosis, basically tissue death inside the teeth,
Yeah.
in those posterior areas when the INN was compromised.
Ooh.
Yeah. It makes posterior segmental alveolar osteotomies inherently riskier from a blood supply perspective.
That's a really critical distinction. So the front can manage, but the back really needs its main highway. And what about during the actual surgery? What are the biggest vascular hazards surgeons worry about?
Well, during procedures like the vertical ramus osteotomy, the VRO we mentioned, surgeons have to carefully navigate around several arteries: the maxillary, the inferior alveolar, the facial artery,
Lots of important vessels there.
definitely. And beyond those large vessels, protecting the blood supply to individual teeth is paramount. Generally, the recommendation is for bone cuts to be at least 5 millimeters away from the toothed pieces, the tips of the roots.
5 millimeters. Seems close.
It is. And some studies show changes in blood flow can occur even at 10 millimeters. So it's a very fine line surgeons have to walk.
So the blood vessels are the lifeline.
Right.
Equally delicate, I imagine, and vital are the nerves. These really dictate the patient's post-operative experience, right?
Absolutely. If blood vessels are the supply lines, nerves are the communication channels. Disrupting them can have profound impacts.
So which nerves are most at risk in these mandibular surgeries?
Primarily, there are two main ones. The marginal mandibular branch of the facial nerve that's mostly a concern in extraoral procedures, cuts on the outside, and then the big one, the inferior alveolar nerve, the EAN, which runs right through the jawbone.
Inside the bone. Yeah.
Right. So the ENN is highly susceptible to damage in almost all mandibular surgeries. The reality is complete avoidance of EN trauma is, well, nearly impossible.
Really?
Impossible.
Not very much.
The surgeon's goal is minimization. And what's surprising, or maybe alarming, is that simply exposing the nerve during surgery, just letting it see the air, can increase the chance of postoperative sensory deficiency.
Just exposing it? Wow. That highlights its fragility.
It really does.
And I understand that the reported nerve damage rates, they can vary wildly in the literature. Why is there such a big range?
You're right, the range is huge. You see reports from 10% to over 90%.
90%.
Yeah. It's a stark reminder of the challenge. A lot of that variation comes down to inconsistent testing methods, how sensation is measured, and different follow-up times in studies. It makes direct comparisons really difficult.
So it's hard to get a single solid number.
Exactly, which underscores why patient-specific risk assessment and really transparent communication about potential nerve changes are so paramount before surgery.
Makes sense. Beyond the INN, is there another nerve that surgeons are particularly concerned about?
Yes, the lingual nerve, it's less frequently damaged, but it's still a risk.
And what does that affect?
It affects taste and sensation in the tongue. Damage usually happens if a bicortical screw one that goes through both sides of the bone over-penetrates during a BSSO procedure.
A technical error, potentially.
Potentially, yes. And interestingly, patients often perceive lingual nerve damage as having a greater impact on their daily activities than EN damage, even though EN issues might be more common. It just highlights the different burdens of various nerve injuries.
Interesting point. Okay, so we've covered lifelines, the blood vessels, and communication lines, the nerves. What about the unseen architects of relapse? The muscles. How do they play into all this?
That's a great way to put it. Orthognathic surgery fundamentally alters the length and the direction of muscle function. Think about those powerful chewing muscles, the temporalis, the masseter, the pterygoids, sometimes grouped as the pterygomasseteric sling.
The sling, right.
And also the suprahyoid muscles under the chin that lift the tongue and jaw. Once the jaw is repositioned surgically, these muscles are suddenly at a new length or pulling at a new angle.
And I don't like that.
Well, their natural pull can significantly contribute to postoperative relapse. They can cause the bone segments to shift back towards their original position.
Like the jaw trying to spring back?
Sort of. For example, the back of the jaw, the gonial region, might move superiorly upwards, or the chin, the symphysis, might drift downward and backward.
That's a crucial point, the body trying to revert to its old habits.
Right.
So I imagine stability, the fixation we talked about, becomes incredibly important here to counteract that muscle pull.
Absolutely essential. Rigid internal fixation, those screws and plates, plays a vital role. It helps hold the bone segments steady long enough for those muscles to adapt, to remodel to the new jaw position.
Okay.
Intermaxillary fixation, where the jaws are just wired shut, often isn't stable enough on its own against these powerful muscle forces.
So wiring shut isn't enough anymore.
Not always, especially for larger movements. And while some interventions like cutting certain supraoid muscles myotomies have been explored to try and prevent relapse,
Cutting the muscles?
yeah, the idea was to reduce that downward pull. But clinical studies haven't consistently supported their effectiveness. Chordonodotomy, however, which involves the temporalis muscle attachment, has been investigated more seriously to manage that muscle's influence.
Okay. So with this fundamental understanding of the body's blueprint, the vessels, nerves, muscles, let's explore the how. The specific techniques surgeons use to reshape the jaw. We can start with some common approaches, maybe beginning with the vertical ramus osteotomy, the VRO.
Good place to start. The VRO is primarily used for mandibular setback, that's correcting horizontal excess, moving the jaw back,
Setting it back.
or for rotation to address asymmetries. It can also achieve minor advancements, but usually only about 2 to 3 millimeters forward, not its main swing.
Got it. And how is it done?
The VRO technique involves an intraoral approach, so all the cuts are made inside the mouth. No external scars,
That's a plus.
definitely. It requires specialized instruments, though, and very careful navigation around crucial landmarks, the sigmoid notch at the top, the posterior border at the back, and of course avoiding that inferior alveolar nerve.
Always watching the nerve.
Always. Surgeons aim to position the proximal fragment, the part still attached, up near the joint laterally to the outside to prevent it from displacing medially after the cut.
Okay. And what are the typical outcomes for VRO? Stability, nerve damage risk.
Well, VRO is known for having a documented anterior relapse, meaning the jaw can drift slightly forward after surgery.
Drifts forward even when you moved it back.
It can, yes, often requiring about a 2 millimeter overcorrection by the surgeon initially to compensate.
Okay, planning for the drift.
Exactly. However, a potential advantage is it generally has a lower incidence of ENN damage compared to the BSSO, which we'll get to.
Lower nerve risk. That's significant.
It is. And another fascinating point, VRO appears to have a low risk for causing TMJ problems and may even benefit patients who already have pre-existing TMJ dysfunction.
Benefit TMJ issues. How?
The exact mechanism isn't fully clear, but the repositioning might unload the joint favorably in some cases. Initial condylar sag, where the joint seems to droop a bit on x-rays right after surgery, is common, but usually resolves over time.
Interesting trade-offs there. Lower nerve risk, possible TMJ benefit, but maybe less stability for setbacks.
That's a fair summary.
So, while VRO offers certain advantages, especially for those setbacks, what if a surgeon needs more flexibility? Maybe for a significant advancement or a less common type of deformity. That's where techniques like the inverted L and C ramus osteotomies come in, right?
Exactly. The inverted L can be used for various horizontal mandibular discrepancies and also open bites. The C osteotomy is mainly indicated for horizontal deficiency needing advancement.
And how are these usually done, inside or outside?
These procedures are generally performed via an extraoral approach.
Okay, so an incision on the outside.
Yes, a small incision, usually below the angle of the jaw. This does raise concerns about visible scarring, of course, and also potential damage to that marginal mandibular branch of the facial nerve we mentioned earlier.
The one controlling the lip corner.
That's the one. Though it's worth noting the reported incidence of permanent nerve damage is actually quite low.
Okay. And a key feature you mentioned earlier for these L and C techniques.
Bone grafting. They often necessitate bone grafting, especially for advancements, to bridge the gap and ensure adequate bone union and stability.
To fill the space you created.
Precisely. Rigid internal fixation is used here too, and studies show it's definitely more stable than the older wire-based methods for advancements, leading to better, more predictable outcomes.
Okay. And then we come to the bilateral sagittal split osteotomy, the BSSO. You said this is like the predominant procedure today.
Without a doubt. It's renowned for its versatility. It can be used to correct virtually all types of mandibular deformities and movements involving the entire horizontal ramus advancements, setbacks, rotations, you name it.
Sounds incredibly versatile. Can you briefly outline the procedure for us? It sounds complex.
It is complex. It's an intraoral technique, again, inside the mouth. It involves making very precise cortical cuts on both sides of the jaw. Imagine carefully splitting the jawbone lengthwise from behind the molars forward to create a mobilized segment.
Splitting the bone. Wow.
Yeah. The surgeon then has to meticulously separate the inferior alveolar nerve, which runs right through that split area, protecting it before repositioning the jaw segment. It's truly an intricate dance of bone cutting and nerve protection.
I can only imagine. And I understand the presence of wisdom teeth, the third molars, can complicate this split.
Absolutely. Having third molars present can make the bone split much more unpredictable. It increases the risk of what we call bad splits or adverse fractures.
Bad splits. Doesn't sound good.
Not good at all. That's why it's often recommended they be removed 9 to 12 months before the BSSO surgery. That allows the bone socket to heal adequately, making the split cleaner and safer.
Plan ahead. Get the wisdom teeth out first.
Usually the best approach. The evolution of fixation for BSSO is also interesting. It moved from those initial wires
Right.
to various screw techniques like lag screws or positional bicortical screws, and also minute plates.
Screws and plates. The rigid fixation.
Exactly. And even newer resorbable screws and plates are being explored. They dissolve over time, avoiding the need for hardware removal later.
Oh, that sounds ideal.
It sounds ideal, but there are trade-offs. Their long-term effects and precise resorption times are still under evaluation, and some studies have noted issues like osteolytic changes, basically bone dissolving around them, and potentially higher relapse rates compared to standard titanium plates. So, still evolving.
Okay, so stability for BSSO, is it consistent?
Oh.
You mentioned issues with VRO setbacks. How does BSO fare?
That's a great question, and it really is a tale of two movements. For advancements, moving the jaw forward, rigid internal fixation, especially using 3 bicortical screws placed in an L configuration, has dramatically improved stability. Relapse rates can be as low as 0 to 8%. Very predictable.
Excellent for advancements, then.
Generally, yes. However, for mandibular setbacks, moving the jaw backward, rigid internal fixation can surprisingly be less stable.
Less stable for setbacks. Why is that?
It seems those paramandibular connective tissues and the muscle vectors we discussed earlier exert more pressure trying to pull the jaw forward again after a setback. Some studies report significant relapse, sometimes up to 50% relapse, for movements greater than 4 millimeters.
50%?
Yeah, one large study showed 21% relapse at just 1 year. So setbacks often necessitate that overcorrection strategy we talked about with VRO.
Right. Plan for the relapse. And the elephant in the room with BSSO seems to be that end damage. What should we really understand about that risk?
You're right. The high incidence of EI and neurosensory problems is a major concern and probably the most discussed complication. Reported rates range widely, as we said, sometimes cited as high as 94%, depending on how strictly damage is defined and tested.
94.
Yeah, though permanent severe numbness is much lower than that. But a significant number of patients will experience some degree of altered sensation, numbness, tingling, hypersensitivity, at least temporarily, and sometimes permanently.
What influences that risk?
Several factors. Patient age is a big one. Older patients generally face a higher risk of persistent sensory changes.
Older nerves don't recover as well.
That seems to be the case. Also, the magnitude of the mandibular movement, bigger moves, stretch the nerve more. And critically, the extent of intraoperative nerve encounter and manipulation. If the nerve is directly bruised or stretched during the split, the risk goes up.
So technique matters immensely.
Immensely. As we discussed, the goal is always minimization, because even just exposing the nerve can increase the chance of postoperative sensory deficiency. It's a constant balancing act between achieving the desired jaw movement and protecting that nerve.
Okay. And what about the jaw joint itself, the TMJ? How does BSSO affect it? We heard VRO might even help sometimes.
Yeah, the relationship between BSO and TMJ dysfunction is, well, complex and debated. Initially, there was fear that rigid fixation might jam the joint and worsen TMJ issues.
Right, locking it in place.
Exactly. But studies show mixed results. Some even suggest a beneficial effect on pre-existing TMJ symptoms, particularly pain and clicking, especially in Class 2 advancements, moving the lower jaw forward for an overbite.
Beneficial? That's surprising.
It is. However, for class 3 setbacks, moving the jaw back for an underbite patients may be less likely to see TMJ improvement, and some studies suggest existing symptoms could potentially worsen. So it seems to depend on the direction of movement and the patient's starting point.
Okay.
It's also vital to be aware of a rare but significant complication called idiopathic condylar resorption.
Idiopathic, meaning you don't know the cause.
Exactly. The condyle, the top part of the jaw joint, inexplicably starts to melt away or resorb after surgery.
That sounds serious.
It is very serious. It predominantly affects young females, often those with pre-existing jaw joint pain or dysfunction, and a specific facial type, a steep mandibular plane angle. It seems particularly associated with large mandibular advancements. The exact cause is still debated.
Wow. That's a lot to consider. What other potential complications should listeners maybe be aware of with BSSO?
Well, we mentioned inadvertent or bad fractures, often linked to those third molars being present.
Right.
There's also the risk of bleeding. Several arteries and veins are in the surgical field, maxillary artery branches, the INN artery itself, facial artery. Usually manageable, but significant bleeding can occur.
Okay.
Airway compromise is another consideration, particularly with setbacks. Moving the jaw backward can narrow the pharyngeal airway space.
Making breathing harder.
Potentially, yes. Studies show reduction in airway width after setback that doesn't always fully recover. It's concern for potential development or worsening of obstructive sleep apnea, OSA.
OSA risk.
Despite all this, though, the risk of significant infection after BSSO is generally quite low thanks to sterile technique and antibiotics, usually less than 5%.
So low infection risk, but definitely some significant potential issues with nerves, TMJ, stability and setbacks, and airway.
That sums it up well. It requires careful patient selection and meticulous surgical technique.
Okay, so while the sagittal split is undoubtedly the big player, the workhorse, there are other specialized techniques that fill important niches in orthognathic surgery. They have their own specific applications and considerations, right?
That's right. We shouldn't forget them. One less common but still powerful technique is mandibular body osteotomies, sometimes called horizontal ramus osteotomy.
Body osteotomies, when are they used?
They're typically reserved for specific situations, maybe cases with missing teeth in the back, creating an edentulous space where a cut is needed, or significant asymmetries, or sometimes where exceptional stability is desired.
Why more stable?
Because the cuts are made anterior to or in front of the main chewing muscles, the pterygomasteric sling. So there's less muscle pull trying to relapse the segments.
Ah, cuts are in front of the muscles. Clever.
But, and this is the big but, the inferior alveolar nerve is right in the line of fire. It runs straight through the area of the cut.
So nerve risk is very high.
Very high. It often requires surgeons to visualize the nerve directly, or even carefully dissect it out and move it temporarily during the procedure nerve lateralization or exteriorization. That obviously increases manipulation and risk.
High stability, high nerve risk. Got it.
And while data is a bit sparse because they're less common, these procedures are generally reported as being very stable long-term.
Okay. Then we have mandibular subapical osteotomies. What are those and how do they differ?
So these include anterior, posterior, and total alveolar osteotomies. They're designed for precision movement of tooth-bearing segments only, rather than moving the whole jaw base.
Just the teeth and their supporting bone?
Exactly. Think of it like cutting out just the block of bone, holding a group of teeth, and repositioning that block. They're less commonly used as primary treatments today, often replaced by orthodontics or BSSO, but still valuable for specific dental alignment issues or closing extraction spaces.
And the main concern there, still nerves.
Nerves are a concern, but the critical consideration here is protecting the blood supply and vitality of the teeth within the segment.
Ah, keeping the teeth alive.
Precisely. Those horizontal cuts must be kept at least 5 millimeters away from the tooth apices, the root tips, to protect the pulpal blood supply.
That 5-millimeter rule again.
Yes. And even with that precaution, significant decreases in pulpal blood flow and some degree of pulpal necrosis are common after these procedures. Clinically, though, surprisingly few teeth ultimately require root canals or extraction. But the risk is definitely there, especially for teeth right next to the vertical cuts.
Okay. And their stability. Are these segmental moves stable?
That's often questioned. Their stability can be less predictable than larger jaw movements. For instance, one study noted an average of 1 millimeter of incisor movement relapse a year after anterior subapical osteotomies. Another showed a 30% recurrence rate for trying to close a maxillary open bite this way. So stability can be a challenge.
Less predictable. Okay. And finally, one that many people might have heard of, even if they don't realize it's orthognathic surgery, the chin surgery, or genioplasty.
Right, the horizontal osteotomy of the symphysis, technically, more commonly known as a genioplasty.
And its primary role.
It's primarily for aesthetic correction of the chin. It can involve advancement, moving it forward, setback backward, vertical augmentation or reduction, making it longer or shorter, or even narrowing it. It's very often performed in conjunction with other major jaw surgeries like BSSO or Laforti maxillary surgery to achieve overall facial balance.
So fine-tuning the profile.
Exactly.
And what does that procedure entail? Is it also intraoral?
Yes, the genioplasty is typically an intraoral approach through an incision inside the lower lip. Paramount importance is placed on carefully protecting the mental nerves.
Mental nerves.
Yeah, they exit the bone in that area and provide sensation to the lower lip and chin. They need to be carefully identified and retracted. Surgeons also meticulously reapproximate the mentalis muscle, the chin muscle, when closing. If that's not done properly, you can get undesirable aesthetic issues like chintosis or a witch's chin deformity.
Ah, the witch's chin. Got it. Avoid that. What about nerve damage risk with genioplasty?
When genioplasty is combined with BSSO, studies show there's often a greater initial IN sensory loss, which may also persist longer, especially in older patients. The combined procedures seem to have an additive effect initially.
More numbness if you do both.
Initially, yes. Genioplasty performed alone typically causes only temporary sensory loss in the chin and lip area from stretching the mental nerves, though a low incidence of long-term altered sensation has been reported.
And for genioplasty, how stable are the results long-term? Does the chin stay where you put it?
Relapse for genioplasty is quite variable. You see reports ranging anywhere from about 2.6% up to 30% for advancements.
30% is quite a lot.
It can be. Most of the relapse seems to occur within the first year after surgery. Factors like patient age, the magnitude of the advancement, bigger moves tend to relapse more, and the influence of the attached soft tissues all play a role.
So some unpredictability there, too.
A degree, yes. Interestingly, some studies show that bone regeneration, the cortical thickness, is better in younger patients after genioplasty. That could potentially be beneficial if any future chin adjustments were ever considered down the line.
Interesting point. This deep dive really highlights that, for all the sophisticated tools and techniques, the underlying anatomy and physiology still dictate so much.
Absolutely. We've really seen this constant push-pull, haven't we, between achieving the ideal functional and aesthetic outcomes the surgeon and patient want and respecting the body's inherent limits, its healing processes, its nerve pathways, its muscle forces.
That's incredible, isn't it? We've journeyed from Houlihan's first tentative cut way back when to today's micro-precision with computer planning and rigid fixation, balancing stability with nerve preservation, understanding those intricate muscle forces, navigating complex TMJ outcomes. It truly underscores how much is involved in these procedures and, frankly, how much is still being learned about exactly how our bodies respond and adapt to these significant changes.
There's always more to learn.
So what does all this mean for you listening? Perhaps it's just a reminder that even in fields as specialized and, let's face it, kind of hardcore as orthognathic surgery, the human body remains this marvel of engineering. It's full of complexities and surprising adaptations.
Indeed.
Considering the intricate dance we've talked about between bone, blood, nerves, and muscles in these surgeries, it really makes you wonder, doesn't it? What other surprising areas of the human body might hold equally complex, yet currently maybe unexplored engineering solutions waiting to be discovered for future medical advancements? Something to think about.